Great, thank you. Um, Good morning, good afternoon. This is Jonathan Webb, the CEO for AMCHP. Thank you for joining us today. As Amy mentioned, it hasn't seemed like that much time has passed, but in this new normal, time is moving very, very quickly. And I want to again thank you for your time here today, but also thank you for the contributions you're making in your communities to keep us all safe. We really appreciate your efforts and your sacrifice on the things you're doing on the ground and for carving time out of your schedules today to be with us. Um, we have a similar agenda to what we did last time with some small changes. So after I finish, we're going to have our federal agency partners to provide us with brief updates. But this time we're going to try to allow for more time to hear from you. One of the benefits of this call, in addition to hearing the really critical things that are happening at the national and federal level, is to hear from you, that your needs, things you're seeing on the ground, things you want to share. And we want to make sure, although we had a really good chat conversation last time, to hear directly from you. So we're going to make sure we allow some time to do just that at the conclusion of the formal portion of this presentation. So without further ado, I'm going to step out of the way and introduce Dr. Michael Warren, who's the Associate Administrator for the Maternal and Child Health Bureau. So Dr. Warren, please take it away.
Good afternoon. Thank you, Jonathan, for all that AMCHP is doing right now to support states. We really appreciate that continued partnership with you all. To our colleagues from CDC, again, thank you for the guidance you're providing, not only to grantees, but also to us as a sister agency. We also appreciate that very much. And to all of the states that are on, as Jonathan said, thank you so much for what you're doing day in and day out on the ground to respond to the needs of MCH populations. I'm going to keep our remarks brief. If we can go to the next slide. Since our last call with you, we heard about questions that you all had on SSDI. On the last call, we talked about the block grant and flexibilities, but folks had asked about changes to SSDI. So if we could advance the slides, I'll walk through our response to that. For the performance report that was originally due May 29th, we're extending that by 2 months to July 29th. You still can submit prior to that date if you'd like, but we've extended that deadline. And then the non-competing continuation progress report, which was going to be due in the first week of September, will now be extended until September 22nd. And that allows you to have some more time there to do that and really focus on the block grant deadline, which is September the 15th. One note about that, the progress report guidance will give you the option for an abbreviated progress report, and that information will be forthcoming in June. But again, that progress report can be abbreviated when you provide it to us in September. Next slide. Another flexibility with SSDI, if you need an extension for your federal financial report or your FFR, you can request an extension for up to 3 months, and you can do that through the EHB. And if you've got questions on that, just reach out to your grants management specialist. So that's all I've got in terms of updates. The last slide just had some resource links, and so when the slides are shared, you'll have those available. Again, we are here to be supportive of you. Please let us know what questions you have. If they relate to specific grants, we can help think through those. Also, we look forward to hearing on this call feedback from you all on what's happening for MCH populations and what needs are. But also, if you have information you want to share in between calls, please feel free to reach out to us. So that's it from us. Thank you.
Thank you so much, Dr. Warren. Really appreciate that update and your leadership through this pandemic. At this point, I'd like to turn it over to Dr. Georgina Peacock. Thank you again for joining us on this call, Dr. Peacock from the CDC's at-risk task force. So I'll turn it over to you now, Dr. Peacock.
Great. And I just wanted to let you know that I think we're also joined with a couple other people from CDC, Jennifer Nelson, Carla DeSisto, and Romeo Galang. So I just wanted to thank you for the opportunity to participate again on this call to provide you with a few CDC updates around the MCH work that is happening within the task force. I'm going to spend just a couple brief moments letting you know the updates to some of our CDC guidance and messaging, as well as some new information that we're developing. So to start off, I wanted to highlight some recent revisions on our considerations for inpatient obstetric healthcare settings. Last week, CDC posted revisions to clarify some of the recommendations. One is in the area of visitors during labor and delivery. And this clarified that visitors to pregnant women with known or suspected COVID-19 should be limited to those essential for the pregnant woman's well-being and care, including emotional support persons. It re-emphasized messages regarding screening and disallowing entry of visitors who are ill, and advising that visitors use the mask policies that are there in the facility. The second clarification was around prioritization of pregnant women for testing, and it clarified that pregnant women admitted with suspected COVID-19 or who develop symptoms concerning or that are concerning for suspected COVID-19 during admission should be prioritized for testing. And finally, there was one more clarification on mother-baby co-location and separation, and it clarified that the determination of whether or not to separate a mother with known or suspected COVID-19 and her infant to reduce risk of transmission should really be made on a case-by-case basis using shared decision-making between the mother and the clinical team, because we know that there are a lot of issues that come into that, and so that is the clarified recommendation. All of these updates do happen on, get updated to the CDC's COVID-19 website. So I encourage you to always go there for additional information if you need that. We're also working on updates to our breastfeeding guidance. We're not planning to change the current recommendations, but we are expanding the guidance by developing some considerations on several subjects that we receive questions on. And to that point, I think listening to calls like this, as well as the information from people who send inquiries in, are really important, because that helps us make sure that we have the guidance that's out there for our MCH colleagues. So in addition to these guidance documents, I think I mentioned on the last call, we're beginning to develop information specific to children and youth with special health care needs based on the feedback that we have from you all. We had a really good call with Dr. Warren, and that should be moving through our process fairly quickly. And then finally, I did want to mention CDC's new cloth face covering guidance. As you know now, that CDC is advising the use of simple cloth face coverings to slow the spread of the virus and help people who may have the virus and don't know from transmitting it to others. So there is a lot of information on the website about this. Of note, we are strengthening the messaging that cloth face covering should not be used in children under the age of 2 because of risks of suffocation. We've also been using our social media channels and many other different ways to communicate to make sure that people are aware of these risks for children under 2. And so I think with that, I am happy to listen to the rest of the call and hear what other help or assistance we could give. I did want to see if my other CDC colleagues had anything to add. I don't know if they're in the panelist list, but if they do, I'm happy to have them add something before I turn it back. Thanks.
Thank you, Dr. Peacock. If you're from the CDC team and would like to make a comment, just please unmute yourself at this time. Okay. Thank you so much, Dr. Peacock, and for your leadership and your team's leadership and your responsiveness to the things that you heard on our call a couple of weeks ago. We really appreciate you taking that back and making the adjustments or adding pieces to the guidance and the resources. So thank you so much for that. As I mentioned earlier in this call, we really want to continue to be able to hear what's happening in your states and your communities on the ground there. So we really want to just open this. We had some good updates, but brief updates, because we really want to hear more from you as to what you may be needing, what you're seeing, things that are working well. We did pose a couple of discussion questions out there, but it's not meant to limit the discussion that we're having today. So please don't assume, don't see that we have discussion item 1 or discussion item 2 and feel like those are the only areas we want to cover. We really want to Dr. Warren's point, hear about what you're experiencing and seeing, and what the impact has been to the MCH population on the ground. So I'm going to open it up. I see a quick item in the chat that I'll mention. I'll call in a second. If you'd like to talk, please unmute your line and just feel free to share. But there's a note here from Michelle Cordell. Do you have any restrictions for other healthy patients or support persons? Should they be allowed to walk about the MCH unit, or should we be limiting them to their rooms? And I believe that question may be for you, Dr. Peacock, and the CDC team.
Can you rephrase that? Sorry.
Yeah, so it sounds like the question is around any additional restrictions for other healthy patients or support persons. Should they be allowed to walk about the MCH unit, or should they be limited to their own room? So I think with some of the updates that you provided, this is
right.
kind of add on to that.
Right. So I certainly, if there's any other CDC colleagues on the phone who want to contribute, please do unmute. This is really probably dependent on the policies of the particular unit that you're in, though I suspect that most places would advise that support person stay in the room with the pregnant woman and not be moving around the entire unit.
Okay, thank you. Another question coming through around when or how we will be informed about the CDC guidance with respect to children and youth with special health care needs. Is this going to take place via a bi-weekly email list, or how are you envisioning that sort of guidance being communicated? I think you're still muted, Dr. Peacock.
Thanks, sorry. When it is finished, we can certainly let you all, our partners at AMCHP, as well as other partners know, we'll let you know that it's updated on the website. I can't give you a date for when it will be out, but as soon as it is ready, we'll be sure to let you know, and at this next subsequent call that you're having, we can also give some updates on that as well.
Thank you. It looks like a couple more questions coming for you, Dr. Peacock, or the CDC team. Should all apparently healthy moms, no COVID test, and newborns be placed in rooming and avoid nurseries?
Again, I think that is going to vary with the particular facility that the mother and baby are in. I know that typically the recommendation is that the babies do room in, so I don't think that recommendation has changed, and except in sort of those very specific situations where there is a need for the baby to go to the nursery. But I expect that following the typical processes would still happen, and keeping that mom close to the baby.
Thank you. And again, a couple more for you. Sorry to put you on the seat, but there's some really good questions coming through here. And then I'll transition to hearing a little bit more from the states around what they may be seeing around some of these in their area. But two more questions. One from Monica Beltran. For the guidance, are you considering doulas as support people?
I think that, and maybe it's someone who was more closely with developing that. It looks like that Romeo Galang, I just got a text, would be able to clarify on that call. So Romeo, could you unmute and answer that question?
Good afternoon. This is Romeo Galang.
Romeo, we can't hear you.
Oh, sorry. Can you hear me now? Hello?
A little better. It's a little muffled, but we can at least make out what you're saying.
I apologize. I'll try speaking a little bit louder if that's helpful. Can you hear me now?
Yes, we can.
Okay, great. So this is really going to be facility dependent, depending upon how the doula is considered by the healthcare facility. If that facility is considering a doula to be healthcare personnel, the important part is that the doula can adhere to all the same infection control recommendations as you would for any other healthcare personnel, including hand hygiene, masking, wearing proper PPE, and of course the support of providing care for that woman. However, I know some facilities, though, may be considering doulas to not be healthcare personnel for that facility, and so they would consider them as a visitor and count them towards the overall visitor count. Again, that's going to be healthcare facility dependent. There's also some guidance on that on the website for the American College of Obstetricians and Gynecologists.
Great, thank you. So if I could summarize that a bit, that it's facility specific and dependent. While some facilities are allowing doulas and considering them to be support, but we have heard of a number of areas where they are not considering doulas as support and are looking at them more as visitors. But it really is site and system specific. Is that a correct synopsis of that?
That's correct. Thank you.
Okay, just wanted to make sure everyone can hear the response. A few more questions here, and if folks want to verbalize these off mute, please feel free to do so. If you're comfortable with me continuing to read them, that's fine. I'm happy to do that as well. Just want to make sure that people don't feel like they have to be limited to the chat box. Question: in light of some people being asymptomatic and screening negative when arriving at the hospital, do you recommend masks for the labor support person?
Hi, this is Romeo Galang again. So each facility is going to have their own mask policy specifically. So I would defer to the facility for what type of mask to use. But generally, for the new guidance on cloth masking still applies to all persons as far as use of masks outside and in scenarios where they can't socially distance. In the facility itself, because it's a healthcare setting, those facilities might recommend a different type of PPE or different type of mask. But generally, visitors and support persons should still be using all precautions recommended.
Thank you, Dr. Galang. Another question from Dawn Bailey. Will the guidance for children and youth with special healthcare needs be for how to manage ongoing medical needs in addition to how to manage COVID-19 testing and care? We are seeing so many restrictions for COVID-19. Accessing care for ongoing needs has been challenging.
Hi, I can start with that, but then I think Dr. Nelson may be on, and if she can unmute, she may have something to add. But we are trying to address the needs of children with special health care needs and their families in some of the questions and answers. So it may take into account sort of that management of other medical needs. that's still under development, and so I think if that is something that needs to be addressed, we may be able to do that. Dr. Nelson, anything else to add?
No, that's great feedback. Right now, it doesn't have anything in the document regarding testing or accessing, COVID type issues. It really is focused on the family and how to prepare, ensure that you have backups, a backup plan in case one of the caregivers gets sick, and some other practical tips for the family, especially about if you have service providers coming into the home, how to adjust to new routines and recommendations and so forth.
And I would also refer people on the CDC COVID-19 website. Right now, there is some guidance for people with disabilities. It's not exactly the same as what would be recommended for children with special health care needs, because that's more targeted at adults with disabilities, but you may find some useful information in there in the interim as this additional guidance is being created.
Thank you. I'm going to pause here for a second. We've got some really good questions coming in from the callers, but I'm going to ask folks to just, those who want to share, to briefly unmute their lines, especially the folks who are representing the children, youth, and special healthcare needs population. And can you share a little bit about what you're seeing or what you're hearing with, given the folks you're representing, some of the challenges you may be seeing on the ground that will be that you'd like folks on this call to better understand?
Hi, Jonathan. This is Noelle Taxon from Utah. We have been doing telehealth with all of our families, and it seems to be working well. One of the challenges we have is the assessments, because you need to be in person. And so that's something I think, depending how long this goes, getting with different companies to figure out how we can assess kids in a different manner to then better work with them.
Thank you. I imagine I'm hearing a lot of telehealth, obviously, given where we are right now, being leveraged for a number of different service provisions. So that's interesting and good to hear that you're using it in this way as well. But it may be something we can build upon as we go, as COVID stays with us for however long it's with us. Anyone else? Thank you for sharing. Anyone else want to chime in?
Jonathan, this is Jacqueline from Tennessee, and one of the challenges that we've seen the last couple of weeks has been families that were previously employed, of course, losing insurance because of unemployment now, and being able to rapidly get coverage and securing medications, and as the question before asked about being able to actually have access to care during a time when most providers are not providing care for anything that's not urgent or emergent or COVID related.
Thank you, Jacqueline. Has there been any kind of, has the states been able to assist in any way with that, or how have you guys been able to or have you been able to address that in any way?
So with our children with special health care needs, we actually are still providing reimbursement for services and assistance with pharmacy. So we're able to do a sort of rapid intake and eligibility process for individuals that are in this situation and help them to get access to at least medication. And if we can help with getting with a visit with a provider, even if it's a telehealth or a virtual visit, we've been doing that, and then working very closely with our Medicaid partners to ensure that individuals are able to apply for and receive Medicaid.
Great, thank you. Thank you. Anyone else would like to share? Okay, I'll jump back. We've got a number of questions that have been coming through on the chat. So I'll jump back to that. We had a couple from Maria Carlos. Should there be universal screening for AR-CoV-2 in women admitted for delivery? And would you recommend universal screening for SARS-CoV-2 in women admitted for delivery to determine hospital isolation practices and bed assignments, inform neonatal care, and guide the use of PPEs?
And Jonathan, you probably missed it, but she actually wrote back a couple of lines later and said to disregard her question. So let's move on to the.
Thank you. I did not see that. Thank you so much. I can't see who generated this. This is coming under Jessica, but just a clarification. Was it said that ACOG also has guidance on doulas in addition to COVID-19 CDC website?
Hi again, this is Romeo Galang. Yes, so we don't actually have specific language around doulas on the CDC website, but the American College of Obstetricians and Gynecologists, so ACOG, does have this under their FAQs on their COVID-19 website. And it reiterates some of what we just stated, which is that really the presence of a doula is going to be facility dependent, and if they're considered by that facility to be a healthcare personnel, we need to make sure that they're able to adhere to the infection prevention control recommendations, including use of the right type of PPE for healthcare personnel. If they're not designated as healthcare personnel by that facility, they would be considered likely within that facility's visitor count for that patient. Over.
Thank you. At the state level, are Title V and Children, Youth, and Special Healthcare Needs staff available for increased support to families with SHIN, including care coordination, medication, advocacy with insurance, and access to care for sustainable services? I think this may be more of a comment given the discussion we were having earlier. But does anyone want to weigh in on that at the state level? Are you finding you're available for that increased support to families with children, youth, and special healthcare needs?
Hello, Jonathan. Can you hear me?
Yes, we can.
Hi, this is Lonnie Barnett calling with the state of Michigan, our Children and Youth with Special Healthcare Needs program. In response to that question, for us in Michigan, the boots on the ground, so to speak, for our CYSHCN program are our local health department staff, nurses, and representatives. And they're actually stretched thinner than ever before because they've been pulled into COVID response follow-up activities within their agency. And so within Michigan, it's, again, in response to the question, it's even, that type of support is less available now than it was before as a result of COVID-19.
Yeah, thank you for that. I mean, that's one of the things that we've had some questions, concerns around. Everyone is obviously responding at various levels, but it really is wearing some of it could potentially be wearing some of the state leadership, pulling them into different directions. And if it's happening at the local level as well, the response is just, it's difficult given the people are now being tasked with so many different things in response to COVID-19. So thank you for sharing that.
Hi, Jonathan. This is Elaine Gabovich in Massachusetts with Children and Youth with Special Health Needs. And so our care coordinators are working very closely with all of their families. But in addition to that, what we're doing is anyone that is in touch with families of which, you know, they've exhausted all of their resources, they've helped families navigate the system, but they are in need of greater support. We've created a tool for all of us to communicate what's happening in the field and then to escalate or to monitor what's happening. So we're working very closely with our sister agencies here in the state, things like our Mass 211 program, or our Office of the Child Advocate, or our Department of Elementary and Secondary Education. We're getting all sorts of different types of questions from families who have children with special health needs or who are medically complex. And I think it's I think we're feeling that we're able to triage a lot of those concerns and move them up, and readily the system, almost right after the question's been answered, in some cases, the system is working behind the scenes to create new policies that are more flexible in this environment. And so we may be able to follow up with our families, or to at least know that system level needs are starting to settle or to become better defined at this point.
That's great. I was going to ask you what the triage process was for that, but thank you for sharing that. In the collecting and gathering of those concerns that are coming through a system like a 211, is it providing you a little more insight into where policies might need to shift or be adjusted because you're able to track it that way?
I think that's where we're heading, and so a lot of folks are collecting information. So as I mentioned, our Office of the Child Advocate is looking to start to collect data and figure out, at a systems level, what kind of outreach they need to do, and then 211 I'm sure is as well, but we have not yet tapped into that. But it's a great question.
Great, thank you. Heading back to our chat box, Marcus Allen from Virginia. One of our biggest struggles has been evaluations of children suspected of having developmental/behavioral conditions. Our case coordinators work over the phone a lot and have adapted nicely. Thank you, Marcus. Sarah Dunn, is there a resource available that provides guidance for personal care attendants or other providers of in-home services for children, youth, and special healthcare needs? Finding info on caring for persons with coronavirus in the home, but not necessarily for caring for persons with disabilities. I'm not sure about that. I'll toss it out to either the CDC, anyone on the call really, the CDC folks or folks at HRSA or other states who may be aware of resources that can help us to respond to Sarah's question here. Again, that's is there a resource available that provides guidance for personal care attendants or other providers of in-home services for children, youth, and special healthcare needs?
So as I referenced before, this is Georgina from CDC. There's some guidance that I don't know if it's posted yet, but it's about to be posted on direct support professionals. A lot of that information in there would be applicable to children with special healthcare needs, though the initial audience was more adults with disabilities. And I think there could be some useful information in there. I also happened to be on a webinar that was done yesterday by the Association of University Centers on Disabilities, and I believe they recorded it. There was a tremendous amount of information on that webinar that I felt was very, very helpful on this topic, and it was recorded, so I will get in touch with the people who recorded that webinar, and I can send you that contact information. Jonathan, you may know Adrienne Griffin at AUCD. She hosted that webinar, and I thought that was incredibly helpful on sort of some of the tricks of the trade of how to really do this in the time of COVID-19. So those are two thoughts that.
Thank you. You froze there at the end there, Dr. Peacock, but I do know Adrienne at AUCD, and if you're able to find it quickly, we'll take that from you. We'll also just reach out to her as well offline to see if we can locate a link to the recording and share that with this group. Thank you so much for that. Susan Chacon in New Mexico, I believe, was offering a response to a question earlier around things being seen on the ground and responses from the state level. In New Mexico, we are increasing our outreach by phone to all of our families and finding that the needs include not only medical, but other issues such as food and behavioral health. We haven't seen any issues with DME yet, and we have been encouraging families to take advantage of the new rule, which allows 3-month refills on meds. Thank you, Susan. Did you want to add any pieces to that, Susan, or are you good with me moving on? That's a great comment.
No, I'm good. Thank you, Jonathan.
Thank you, Susan. There's an answer to an earlier question. We're all kind of coming in under Jessica, so I'm not exactly sure which question this was related to, but it says our staff in Alabama have been in touch with families we have a relationship with to meet these needs, and also available to work with families with newly identified needs. So that may be how the state Title V and SHIN staff have been working to advocate and support their families in needs. I think that's what that was responding to. In California, we have created a document of tips and resources for families of children, youth, and special healthcare needs in response to the greatest needs shared with us by our family serving organization partners. The link is in the chat box for folks. We are also coming out soon with printable versions in English and Spanish. If you're looking for more information on this, this comment was offered by Sarah Leff, and her email is in the chat as well. Sarah Leff, L-E-F-F, if you're interested in learning more. A few more questions and comments coming in here. Families are reporting shortages of some supplies such as feeding pump bags and of course gloves and masks. They're also feeling challenges with school services and in-home supports. This was one of the concerns I've heard on a consistent basis, is that if a child or youth with special health care need was receiving services through his or her school, it can be a challenge now that schools in most places are closed and shut down. How are folks getting those supports to maintain their progress? Okay. From Hawaii, many of the licensed personnel are deployed to the COVID-19 investigation and monitoring as we are building the medical reserve Corps volunteers to help with some of the investigation and monitoring. So those are the comments we have thus far. Thank you all for that discussion, for that portion of the call. I'll quickly ask if anyone else has any other comments that they wanted to weigh in or share with respect to either the children with special health care needs population or just in general, things they're seeing from a birth. We started to have a conversation around birth settings and labor and delivery practices and questions. Anything that you want to share that you're seeing on the ground related to those three areas? Okay, one final comment from Lonnie. That gets maybe a couple other comments. It's very challenging, Lonnie Barnett, it's very challenging to address the increase in demand for our children, youth, and special health care needs services, while at the same time, due to emerging state budget constraints, to identify potential budget reductions for the current fiscal year and the next fiscal year. Very challenging times. We have a parent of a youth with special health care needs. All of my in-home support CNAs has been halted due to potential exposure. Thank you for sharing that. We're tracking these. One of the things I should have mentioned or reiterated for this call, as I did at the last call, is that AMCHP has stood up internally a COVID team. And we're using this call along with our partners to get a better sense of what's happening. So as we're collecting these and hearing of the things that are happening, we can figure out what AMCHP's response can be along with our federal partners and leaders on this call as to how we might support some of these challenges or share with others who may be able to better support some of these challenges. So thank you for vulnerability and the opportunity to share with us today. Many hospitals and clinical services have furloughed their personnel in a quarantine territory. This limits services available for clinical services. Thank you. So shifting focus a little bit, our next topic is around health disparities. So this is a topic of conversation that we've seen and heard come up a lot lately with respect to the inequities and the distribution of COVID and challenges that individuals, communities are experiencing. I won't go any further from an AMCHP perspective or bias anyone's comments, but I'd love to hear from you things that you're seeing on the ground with respect to these health disparities related to COVID. And when you just remember to unmute your line as you're talking. Anything that the states are seeing, or anyone even outside of the states or not maybe in formal state government want to share about what you're seeing in terms of health disparities or hearing?
Hi, everyone. This is Becky in Louisiana. We have really stark disparities in the COVID outcomes for African Americans. I think at one point, 70% of the deaths were African American in Louisiana, and that so the governor has put together a health disparities task force, and the Department of Health has also pulled together some joint messaging across all departments about the stay-at-home order and just things people can do and put a hashtag together of we are in this together. So we're coordinating a communication campaign around it and also tracking the data.
Thank you. And thank you also. I believe I saw an earlier report that Louisiana is one of the states that has been tracking their and releasing, sharing their data. We'll get into a data conversation a little bit later, but thank you for sharing that and for the work you're doing. Any others like to share around that?
Jonathan, this is Marilyn Johnson. Can you hear me just fine?
I can, yep.
So in Mississippi, our numbers, we're sharing data and releasing data as well as far as disparities are concerned. But we've agreed that we have to tackle this not only from a standpoint of the Mississippi State Department of Health, but we've also established some grassroots efforts in communities with community-based organizations, with those champions in the communities who we know are, sorry, I was getting my lunch.
All right.
Those people who we know will rally for the cause. Some of them have gone as far to develop infographics and things of that nature. We're on calls with sororities and fraternities. So it's an approach where you have it coming from the state level, which is your state health department, but we also know that the roots in the community are deep for Mississippi, so we've got to tackle this in more than one way. We have a survey from the State Department of Health that we deployed on last night. We now have a health disparities response team. Dr. Victor Studden and Dr. Ugumde, they're over that health disparities response team. So looking at how our state is, how rural we are, knowing some of the challenges we face, we just thought that it would be better if we came from the state level and also just really dig into that community part.
Thank you, Marilyn. And thank you for sharing your data as well. I'm curious, in Mississippi or Louisiana or anyone else who's doing these kind of efforts, how are you addressing messaging so that, as I think you talked about engaging stakeholders, for lack of a better term, maybe gatekeepers within communities, but how are you addressing messaging for that community, but then also for the broader community, so we're not, let's not say blaming populations for some of the things that they're experiencing. We obviously know that there may be some other social determinants that may be putting folks more at risk for some of these things. Have you had to address that, or how? And if you have, how are you handling the messaging around that?
This is Becky from Louisiana. So we're definitely, we have a checklist that we've developed a couple of years back about how to check our communications and make sure that they don't stigmatize the populations we're trying to reach. And we're making sure to avoid language that blames the population, because ultimately we acknowledge the group that's working on the messaging acknowledges that the health disparities are due to racism, and that racism isn't a short-term fix. Right now, what we're trying to do is figure out what things you can do in the short term to keep people safe from getting exposed to the infection instead of, or not infection, but you know what I mean. And so we're reaching out to churches. There was also LPHI, Louisiana Public Health Institute, had worked with the Urban League of Louisiana to put on a pretty intensive virtual town hall on Wednesday. I think it was Tuesday evening, just to cover what people can do. And the messaging is not about blaming. It's about how do you stay safe, and how do you respect culture, and how do you make sure that faith leaders are involved, and trying to get leaders from in the community to be the voice for social distancing and safety.
Great, thank you so much for that.
So I'll make this real quick, Jonathan. Another thing with messaging we're doing in Mississippi is we're trying not to use terms or terminology that's confusing. Some people may not know, they may not know diabetes. So we say sugar. We know they know the term sugar. Big Mama had sugar.
Yeah.
So we're trying to do the messaging in a way where we're targeting the specific communities, and also looking at the messaging in a way where that particular community will be responsive. You may have generations of people in one household. So it's important to do the messaging in a way that you can reach multiple generations. So that's all I'll add to that part.
No, that's great. That's great. Thank you for that. I think that's important. There are a few comments that were coming through on the chat. I want to make sure we get to them as well. Apologize if some of these may step back, but for a while we have talked about the need for increasing our knowledge and practice on trauma-informed care. We need to increase our efforts on expanding our knowledge quickly in order to meet the needs that will be there once we're out of the pandemic. Great point. In New Mexico, 30% of our COVID cases are in Native Americans. We do post-ethnicity on our DOH case reporting website, as well as county. Another comment, testing PPE are reassigned to hotspots, making it less available for other regions, some more isolated by geography or financial limits. Thank you. Question from Ileana White. Are any of your states releasing COVID-19 data by zip codes and racial ethnicity breakdowns?
Louisiana is doing it by parish. I can put our website for our state health department on there on the chat. We've got a pretty great dashboard.
Thank you, Louisiana. I believe Tennessee was as well. And I think California, I don't know if others, Michigan maybe, I don't know if other states are doing this as well. Is anyone willing to share if their states are doing that?
What was the question again, Jonathan? This is Jacqueline from Tennessee. I missed the question.
Are any of your states releasing COVID-19 data by zip codes and racial and ethnicity background breakdowns?
The data that's being presented on the website daily does have some race and ethnicity. There's also some hotspot maps that are being developed by zip code, I know from the local standpoint, and then there are other data that's being collected that's not necessarily in a public format or on a public forum that we can request reports from if individuals or if others need that data.
Thank you. There's a comment in here that Maryland is doing that by zip code at least. So that's a piece of this. I I know we've had some conversations about the importance of being able to track this data, and you'll actually hear a little bit more about this in some of the communications and via email about suggested ways for how to track this kind of information so we don't lose this point in time information. And I think to an earlier comment, as we're coming out of the pandemic, it'd be great to see longitudinally what some of the impacts in communities are who've been impacted by COVID. So keeping that in mind.
Hey, Jonathan, this is Marcus.
Hey, Marcus.
Virginia is doing some of that with cases by health districts and also some data on race and ethnicity. So people can go to the VDH, Virginia Department of Health website, and the data is posted there.
Thank you. And I'm looking at some of the comments in here. Arizona is releasing by zip code only. Louisiana is in here. New York is doing it by counties, and we have a great dashboard. New Mexico is only doing county at this point, not zip code. Massachusetts is releasing by city, town, and by race ethnicity. South Carolina is doing it by zip code. So in the chat box there, folks are responding with links as well. Michigan reporting by age, race, ethnicity, etc., and also county reporting. So there's some good responses to your question in there, Ileana. This is a question for the CDC. Rebecca Maurice. We are holding a perinatal echo related to COVID for providers in Alaska. One thing that has come up is the recommendation to not consider newborns of mom with suspected COVID-19 under suspicion. Some providers have asked if this is still under discussion or being reconsidered.
Hi, good afternoon. This is Romeo Galong. I can answer that question. So that was a one line that was in the recent update to the inpatient OB guidance. After receiving some feedback and some input from partners in the field like yourselves, we've actually taken a closer look and we're able to remove that one statement from the guidance. The concern here, just to cap it for everybody, is that if you have a pregnant woman on labor and delivery who is highly suspected of having COVID-19, that testing might not be back in time to confirm that she has infection, and then the infant would be under special infection control precautions. We've walked that back so that line is no longer there. We would say that that's likely up to clinical judgment now as to whether or not to consider that infant to be suspected themselves and to use like the precautions that are in the guidance. Over.
Thank you, Romeo. I appreciate that. Just going back to your question, Ileana, there are also a number. Hawaii is by island and zip code. Delaware is reporting data by county. So just flagging for you that there are a number of states that are responding to that. But thank you, Romeo, for your comments. Monica shared earlier that regarding health disparities, Trust for America's Health and other advocacy organizations are pushing for COVID data to be disaggregated. Thank you. Lauren Tobias, New York is increasing testing sites in communities of color, improve collecting and reporting on data related to race. In addition, there will be a task force that looks at these disparities, or the disparities. Thank you, Lauren. Hawaii, Children with Special Healthcare Needs Genetics Program, developed telehealth resources, including short videos for providers and families, what to expect from a telehealth visit and telehealth best practices. And there's a resource available. The website is listed in the chat box. Thank you, Dr. Peacock, for your comments. We're glad to have you as part of this call. Let me see if there, I'll use this as the final question before we close out. Jonathan Borden was asking, is the guidance being used by Mississippi regarding appropriate language for disparate outcome discussions something that can be shared? So I think that's directed towards you, Marilyn.
What was the question again? I'm sorry.
Is the guidance being used by Mississippi regarding appropriate language for disparate outcome discussions something that can be shared?
It is.
If there's information that you'd like to be shared, if you wouldn't mind sending it to me at jwebb@amchp.org, we can make sure it gets out to the folks on this call.
Okay, will do.
Thank you, and thank you for the question, Jonathan. Really quickly, I just wanted to make you aware of a couple of things. First thing, thank you for the great conversation and the great questions. A special thank you to our MCHB and CDC leadership for taking time and committing to being a part of this discussion. We really value your participation and being able to provide some of the guidance that you've been able to do over the last several weeks to this group. And thank you for those on the call for committing to be to be a part of this and sharing openly what your challenges are and what your successes may be in terms of how you're addressing this. We really are trying to create provide an environment where you get good information, but also have a chance to share with your colleagues and peers about things that are working, things that you're still having challenges with, and collectively we can troubleshoot those for you. I did want to make you aware that one of the things that we would like to do over the next week or so is to share out with our MCH and SHIN directors a brief survey to better understand what the impact of COVID has been from an operational standpoint. It's a 2 or 3 question survey that we would ask you to prioritize just to help us and our federal agency partners understand, how is your working environment transitioned? Were you able to seamlessly transition to telehealth? The survey questions are fairly straightforward, but it'll give us a better understanding of what the operational impacts have been, so we can also add that to the list of things that we need to be mindful of, and willing to jump in to help if we can to address some of those in this new normal. There also will be conversations and emails coming out around data. We firmly believe that data is going to be very critical to track and get a better sense of what's happening now. Are we missing things around maternal mortality, infant mortality? Are we a standardized way looking at what's occurring so that we can also be tracking it, as I mentioned earlier, from a longitudinal standpoint to see what the long-term impacts of COVID have been? Are we leveraging some existing surveillance systems that we can be learning from as we're doing that? So more to come from AMCHP and our partners to gauge what the need is and how we can best support you. Dr. Warren, I know you're still on the call as well. I don't know if you'd like to say a few words to close us out. We always appreciate your involvement in this, but I wanted to make sure you wanted to see if you wanted to say something before we wrap up.
Just thank you for all taking the time to share your thoughts with us. As Jonathan said, this is so important for us to hear from you. I've been feverishly taking notes as you've been talking, and please continue to share that feedback. Dr. Peacock also said that in her notes. This is how we hear what's going on and how we can be responsive. So please keep the conversation going. And AMCHP, thank you for facilitating this and for having us be a part of it.
No problem. Thank you. And I think Dr. Peacock had to jump off, but Romeo, did you want to say anything on behalf of the CDC team before we wrap up? Romeo may have jumped off as well. There was a question really quickly that I want to make sure that just came through. Who asked the question about ACF? Can you let us know who you are? Okay, thank you. Jenny did that. So great. We have you in there as well, Jenny Bissell. asked about ACF. Thank you all again for your time today. Our next scheduled conversation is Thursday, April 30th. Same bat time, same bat channel. And we look forward to seeing you there. Thank you again for your time today. And Amy and Jess, thank you for your help in pulling all this together. Have a great week.